This episode is brought to you by Promensal.
With us all getting old, healthier and older, thankfully, so an ageing population, we're going to get to a stage where women are living eventually half their lives post-menopause. So that's why this stuff about, timely health interventions at menopause is so crucial to making sure that we're really, really healthy in older life.
Welcome to Thriving in Menopause, brought to you by Prevention Magazine. I'm Zoe Mernier, the editor of Prevention. Thank you for joining me for episode 3 of season 9. Today on the podcast, we'll be taking a dive into the different stages of menopause, because the experiences, changes and symptoms that we experience at the beginning of our menopausal journey can be very different to those we experience at the end. And of course, the treatments that we might need along the way will also vary. With so much going on in our bodies, it's also a time that we should be being very vigilant with our health checks and medical appointments, which, believe me, I know can be pretty challenging when we already have so much going on in our lives. But it really is so important. To explain why and to help guide us through the confusion, I'm very happy to be joined by one of Australia's leading voices in menopausal treatment for women, Dr Kelly Teagle, GP and founder of WellFem, a telehealth-only menopausal clinic offering services Australia-wide to people going through the menopausal transition. She has also just launched a new program to help support people through the postmenopausal journey, which we'll talk more about later. Kelly, hello. Thank you for joining us today.
Thank you. It's a pleasure.
First of all, can we talk about the stages of menopause? Because I think there is a lot of confusion around this. Now, we know, or in fact, some of us don't know, as I discovered recently, but menopause is technically just a day in the diary that marks the date when it was 12 months since your last menstrual period. But I was recently reading an article of yours in which you reference various menopause stages, including early perimenopause, late perimenopause, as well as early and late menopause. So how are these stages classified and broken down?
Yeah, that's a very good question. It all gets very confusing. And, up until probably the last few years, we didn't really have an official word or diagnosis of perimenopause. It's just a term that's sort of come to be recognised as that build-up stage to actual menopause, which is when you ovulate your last egg. And look, there's lots of, as always, very complicated medical classifications for these things. There's actually a thing called the straw criteria. It's the stages of reproductive aging workshop criteria, which is like a great big graph, and it's all referenced around the day that you pop out your last egg. So, there's that's time 0, and going back into perimenopause, -1, -2, -3, and then +1, +2, +3. So it's all referenced around that particular time. It gets very, very confusing. When I do my talks in this subject, I actually flash it up on screen and I go, see that thing there, how complicated that is? Now forget all about it because it's all too confusing.
Yeah.
So I like to break it down and really just think about it in practical terms for patients and for people as 3 main stages. So you've kind of got perimenopause, which is the build-up to your final ovulation. You've got menopause, which is diagnosed retrospectively when you've actually gone 12 months without a period. And then every time thereafter is called postmenopause. And incidentally, with us all getting old, healthier and older, thankfully, so an ageing population, we're going to get to a stage where women are living eventually half their lives post-menopause. So that's why this stuff about, timely health interventions at menopause is so crucial to making sure that we're really, really healthy in older life. So we've got the perimenopause, the menopause, and the postmenopause. But when I talk about early and late perimenopause and early and late postmenopause, that's just a way of, I guess, being able to break that down a little bit more based on the types of symptoms that the woman's having. So, in perimenopause, are they having somewhat regular periods, or are they having really all over the shop infrequent periods? That might be a signal that they're either in early or late perimenopause.
Gotcha. Now, you've also discussed that our hormonal changes in early perimenopause are very different from the hormonal state in other stages. So can you talk about how those hormonal changes differ throughout each period?
Yes, yes. And this is really key to understanding the symptoms that can evolve in the different stages of
Yeah.
the menopausal transition. So I have this beautiful diagram that I like to flash up for my presentations, and it's not so complicated as the other one, thankfully. So when you think about it, you've got this kind of nice rhythmic kind of up and down cyclical thing happening with your reproductive hormones during your reproductive years. And then post-menopause, once you've had your final ovulation, that's actually very stable and flatline essentially,
Yeah.
with the levels of these hormones being quite low. But in between, it's not a nice gentle ramping down as your hormones decline. What in fact happens, because as you start to run out of eggs, as your eggs start to age and you're running out, your ovaries are almost sputtering, like they're sort of popping out one here, there, everywhere.
Right.
And that leads to a lot of chaos and a lot of instability in what's happening with your reproductive hormones, which in turn then makes a lot of instability in your brain chemistry as well. So that's really key to understanding why you get certain symptoms worse in perimenopause while your ovaries are doing that stop-start sputtering kind of thing, versus the types of symptoms that you get post-menopause when everything's much more stable, but you've got actually very, very pervasively low estrogen and progesterone afterwards.
Right. So how does this manifest in the different symptoms that women might experience over time?
So the natural history is, let's say, early perimenopause. You might still actually be having plumb normal regular periods, pretty much as same as you always have. But it might be that as you're getting older, your ovaries are less efficient at producing the hormones that it's been used to producing. So there can be subtle shifts in the ratios between estrogen and progesterone. So you might start to see worsening of your cyclical mood symptoms, for example, or you're starting to get worsening premenstrual migraines or heavier periods because perhaps you've not got as much progesterone relative to estrogen as you used to have.
Right.
Then as you move through and you start to get maybe longer gaps between your periods or even shorter gaps between your periods. So you're starting to see little shifts in the length of your cycle. You might even start to have some cycles where there's a really big gap opening up. And that's signaling the start of maybe a change in your ovulatory pattern. And when you get to the point where you're actually really all over the place, where you're getting sort of infrequent periods, where you're getting big gaps sort of opening up, might be more than 2 months. And you might start to notice, for example, that you're getting times when you're getting quite bad hot flushes or night sweats. You might not have periods as frequently, but they might be super heavy flooding monsters of periods when they do come. And that's called dysfunctional uterine bleeding. So, the main kind of mood symptoms, though, this is interesting, is because of all of that instability of the hormones around that time in perimenopause. That makes it much more likely that women are either going to have for the first time or perhaps a recurrence that's even worse than previously of mental health symptoms like depression and anxiety. Now, it might be cyclical, so that might give us a clue that it's hormonal, but it may not be, especially if you've got like no periods because you have a marina or something, or you're having really infrequent periods. So it's hard to tell.
And then does that usually continue on into postmenopause, or what are the sort of symptoms that are generally more prevalent during that period?
Yeah. So obviously the period thing.
Lack thereof, I should say. Yes.
There's got to be some plus side here, doesn't there?
Right.
So the periods definitely stop at menopause, as they should. But what happens then, as I mentioned earlier, you've got that pervasively low levels of estrogen and progesterone from there on in. And that has really, really important physiological effects that every person needs to know about, because if we don't take the right kinds of actions at midlife around when menopause starts, then we can't help to deal with the consequences. So what I'm talking about is that there's a very rapid, there's an increase in the rate of decline of bone loss that starts to happen from menopause. There's a rise in your heart disease risk. There's a rise in dementia risk. There's all of these kinds of long-term consequences. And in terms of symptoms, your mental health symptoms actually are more likely to settle down, believe it or not, because you don't have the up and down hormonal chaos happening anymore. So there's some light at the end of the tunnel if you're someone who's got perimenopausal mood symptoms, is that it's far likelier that postmenopausally that's going to settle down quite a lot. So that side of it will be improved, but these other things like the long-term health impacts on your body and mind overall really start to kick in, and things that you may not expect too, like vaginal dryness. Now that's something that is definitely a feature of low estrogen, and not every woman gets it badly, but most women will get it eventually, because the longer post-menopause you get, the more of an impact that low estrogen environment has on the vulvovaginal tissue. So it becomes quite dry and it becomes a bit fragile. So it's super important to get on top of those kinds of symptoms early, because it could be as simple as, getting your GP to prescribe some vaginal estrogens, for example. Even if you don't need systemic estrogens for hot flushes or any other symptoms, it might be a very easy, simple thing to use some vaginal estrogens, which really directly improve the tone and resilience of the vaginal tissues and really stop the sort of regression of the labia and things that can happen over time if we don't get on top of it.
On top of it, yeah, absolutely.
Yeah.
What about symptoms like brain fog and fatigue? Do they generally ease off post-menopause as well?
Yeah, that's a little harder to define, because the problem is we don't kind of live our life in a nice, neat, scientific little bubble where we can control all the variables and we can inject something into the bubble and go, oh, look, that makes them better. The problem is that we're all moving through our lives with very complicated, multiple inputs from all different areas. So, stressful work, aging parents, difficult teenage kids, physical decline or poor health, might be anything, relationship problems, you name it. So all of these things are impacting on our symptoms. You've got other potential medical problems going on as well. So for example, if you've got super heavy flooding periods in perimenopause, it's far more likely that you're going to have low iron levels, which of course are a famous kind of contributor to fatigue or cause of fatigue. So all of those things have to be really looked at in a holistic way to try and work out, well, how much of a player is the hormonal component versus all the other things. And, sometimes it can be surprising when we start women on hormonal therapy that they go, wow, I never knew that thing was an estrogen symptom until I took estrogen and it got better. So sometimes just trialing some of these things or using it for, say, hot flushes and then finding that incidentally it has these other knock-on effects to other systems can be quite informative.
Absolutely.
But really, the answer is we just don't know. Brain fog is definitely a big thing that happens during that time of hormonal chaos that's impacting our brain. And just like mood, that does reportedly get better for a lot of women postmenopausally. Now, whether that is that actually their cognitive faculties go back to where they were before, or whether they just get used to the fact that they're not as sharp as they used to be and that's their new normal. It's a little bit hard to know, but we know there's a lot of mad rewiring going on in your brain around menopause.
We'll be right back after this.
Perimenopause can actually start in your 40s. Declining estrogen production during perimenopause brings on changes to menstrual cycles and often the onset of hot flushes, night sweats, mood swings, and sexual problems. Promensal Peri is specifically designed for perimenopausal women and can help relieve these common menopausal symptoms. Promensal Peri is available at leading pharmacies across Australia and offers a cost-effective treatment at under $1 a day. When things start to change, try Promensal Peri. Always read the label and follow the directions for use.
Okay, we're back. You've talked about the fact that treatments can be so helpful with preventing a lot of those diseases and issues that can come up post-menopause, like dementia and heart disease. Now, if you're someone that's not really experiencing a lot of symptoms, you're not getting the hot flushes, you're managing it all, should you still be looking at getting treatment because of all those benefit that it gives you for other things. So as someone that,
absolutely.
Would you be potentially missing out on some really good benefits to your body in terms of prevention of disease and decline if you're otherwise okay managing your symptoms?
That's a really interesting question, and because there's no right answer to this question. It's such a personal area of medicine, and it's so individualized. So internationally speaking, in terms of recommendations of, why we use medications for certain things, and in the Australian context, the main indication for using estrogen therapy, for example, is debilitating hot flushes or osteoporosis. The reality is that those aren't the only reasons we prescribe it, and there are many, many. So patients will come along and they've, done some reading, research, been talking to their neighbour or on a Facebook group or something, and heard about the benefits that, their friends are getting. And they say, well, I'm curious to know whether this might be of benefit to me, which is absolutely valid because, who doesn't want to, know all that they can know about what's happening in their body and how to do the best thing that they can for it. So, they'll come along and we'll have that conversation. Well, do you have terrible hot flushes or osteoporosis? No, you don't. Well, are these things likely to help improve my symptoms? I don't know is the answer in most cases, because until we try something, we really don't know how much of an impact the hormones are having on that particular symptom and how much a treatment with a hormone is likely to improve it. So it is very individual and trial and error in that respect. But we do have that conversation where I explain that it's an off-label use. It's not something that it's been tested for and specifically recommended for, but we will explore whether or not there are any, for example, contraindications, which means, do they have any other medical reasons which would mean that it wouldn't be safe to use it?
Yeah.
And the reality is that for the majority of women that have menopausal symptoms, they're going to find that using menopausal hormone therapy is a very low risk proposition. So we often get to the place where we go, well, I don't know, whether this is going to help you or not, but I assess that it's quite a low risk thing for you to try. And if you want to try it, then I'll support you in that. And then we do a trial of it and see if they feel better. So yeah, the reality is symptom wise, we often use it off label. There are very few countries internationally that actually recommend menopausal hormone therapy for preventive health reasons. Right. The majority of international menopause societies don't say that it's recommended for prevention of chronic disease, but we do know that it is a very nice side effect of being on estrogen therapy, that it's going to have this legacy benefit of the duration of time that you're on it. It helps to prevent that rise in heart disease risk and the drop in the bone density. And we're getting more and more evidence of perhaps impact in, helping to prevent dementia and cognitive decline as well.
Amazing.
Yeah.
Okay, so what sort of questions should we be asking our menopause practitioners or GPs to ensure our treatments are getting updated or that they're still necessary? So if we have been given a treatment, like how long should we be waiting until we check back in, and what should we be looking out for?
Well, my advice, even to patients when I've got them established on their treatment and, they're not wanting to change anything and it's all very stable and they're happy, I say to them we should check in at least 12 monthly, because at this time of life it's critical to make sure that they're staying on top of their screening activities, that they haven't developed any new medical conditions which might be contraindications to being on the hormonal treatment, that maybe we don't need to consider changing the dose or the way that we're using it. One example of that is that if you're perimenopausal, and keeping in mind that there's actually no TGA approved hormonal treatments, menopausal hormone treatments for use in perimenopause, it's all off label, believe it or not.
Right.
But if they are in perimenopause and they're having a cycle, they're having some regular bleeding, then we need to use a cyclical approach to using the hormones. Whereas postmenopausally, when they're not bleeding anymore, it's more of a continuous style of therapy that doesn't change, throughout the month. So that, we might need to make that shift at some point. And if their symptoms are getting more stable and they've been on it for a really long time, it might be time to say, shall we maybe go off it and see if you still need to be on it, if the symptoms are still there that you were using it for in the first place. Having said that, I've got lots of patients who are well aware of the long-term health benefits of their MHT, and they go, I don't care whether it's helping my symptoms or not, I'm not going off it.
Right. Yeah, absolutely.
So that's just a matter of making sure that it's safe for them to continue being on it and talking about how to use it in the safest possible way in the lowest effective dose.
Yeah, for sure. I mean, now you mentioned previously that, keeping up with screenings is very important. So what sort of screenings are most critical for women as they go through the menopause transition?
Yeah. Good question. And so this is where having a local GP, even if you're using our telehealth service for a bit of expert menopause advice, you absolutely have to have a GP that you have trust in your local area that can kind of keep tabs on your screening activities and who can be your go-to person when you really have a health crisis or you need to be physically examined. So, things like, for example, your regular cervical screening tests, obviously very important. Mammograms, super, super important because as I say to my own patients, we've all got a 1 in 7 lifetime risk of developing breast cancer. And I've had it myself, and that was detected on a mammogram, a routine mammogram. So, it's super important to remember that regardless of whether you're on MHT, you've got a 1 in 7 lifetime risk. And for people who are, very overweight or drinking too much alcohol or sedentary or a strong family history or a number of other things, they might even have much higher risk than that. So, there's a good chance that you could develop breast cancer in your lifetime. Now, being on the hormonal products doesn't necessarily increase that risk by a great deal. But if you are the 1 in 7 and you're developing an early breast cancer and you remain on your hormonal products, you could be accelerating the cancer. So the main message here is early detection, just making sure that you're doing, say, monthly breast self-examinations to get to know your breasts and if anything's changing, and also doing your regular recommended mammograms every 2 years. So those are absolute no-brainers, as is getting a regular blood pressure check. Should be doing that minimum 12 monthly, and certainly beyond the age of 50, every year or two, getting some fasting blood tests so that you can make sure your cholesterol's not creeping up or you're developing insulin resistance. That might be an early marker of diabetes. And your GP can do what's called a cardiovascular risk assessment. There's an online calculator called the Oz CVD risk calculator, and you can punch in all these numbers and work out what your risk of having a cardiovascular event is in the next 5 years.
Wow.
And that's important information when it comes to making decisions like, do you need to be on a medication to lower your cholesterol or your blood pressure or something like that? So all of these things need to be revisited on a regular basis. It's just maintenance and prevention.
Absolutely. Because obviously if we do develop certain conditions, it can interact with other menopausal treatments. As you said, for example, with breast cancer, being on estrogen therapy could accelerate it. Can you talk about other ways that menopausal treatments could interfere with certain conditions?
Look, there's not a whole lot of contraindications when it comes to hormonal treatment. So one of them is an active estrogen-sensitive cancer. Of course, you would need to come off the hormones and get that dealt with before anything else could be considered. So when it comes to autoimmune diseases, for example, something like a severe active case of lupus might be exacerbated by being on estrogen therapy because estrogen is an immune booster. So sometimes there's a bit of an unknown for people who have autoimmune diseases, just exactly how the estrogen might impact on that.
Now, I know some women will be listening to all this and saying they don't have time for all these appointments, but that's where telehealth services, such as WellFem really come into their own, right?
Absolutely. I mean, the reason why WellFem was created was because I was aware that there are a lot of women out there who weren't able to access good menopause advice, and particularly I was worried about women in rural and remote areas. But having said that, lots and lots of women in urban areas have bounced from doctor to doctor and not been able to get the menopause advice that they needed. So we do hear that a lot when people are booking in, that they just haven't been able to get any decent information or treatment. And it's convenient, I mean, obviously it's nice for people to be able to be in their own comfortable environment, feeling secure, and have the appointment at a time that suits them without having to travel.
For sure. Okay, so tell us about the new program you've launched to support women through their postmenopausal journey.
I'm really, really excited about this project, actually. When I started WellFem, it was a passion project because I knew that women were suffering dreadfully with symptoms and just couldn't get the care they needed. But once you get women sorted out with that treatment and they're feeling better and their symptoms are well managed, the next big frontier, the thing that's going to make the biggest difference to their health and well-being long-term, of course, is being able to make those timely changes at midlife that will really impact on their future health. So for all the reasons that I've mentioned earlier, the bone loss, the rise in heart disease risk, the increased risk of dementia, and dementia and heart disease are like the two biggest killers of women in Australia. So that's what we need to stay firmly focused on in terms of our future long-term health and well-being. Because we don't want to be a frail little old lady that, can't be independent, can't carry her groceries, breaks when she falls over in a stiff breeze. You want to remain a strong, healthy, independent, person who's got an enriched life with good quality relationships and has the function to do the things that you want to do. So that's why I started Next Phase. It's a women's wellness program that's just focused on education and support to help women identify what key little things they can be doing now, even squishing them into their busy daily life, that are going to be really amplified powerfully over decades to really make that huge difference in terms of their long-term well-being and longevity. And that's what it's all about. So it's a 10-module program, and they get up to 6 months to work their way through all the material, and they can even subscribe for longer if they want or need to. And it includes not just online education components, but we've also got personal and small group coaching and an online community. So it's really supportive. There's accountability. It is not like, this is what you should eat, this is what you should do for exercise, take this, do that, whatever. It's not prescriptive at all. It's very, very designed to help you identify the things that you need to do and that will work for you in your life, and then give you the support you need to be able to implement it. Because everyone needs permission at our age, women particularly, to actually take the time to look after themselves.
I know, yes. It's so true. So that's www.nextphasewellness.com for people that want to learn more. That is great. Kelly, thank you so much for joining us today. That's all we have time for, unfortunately, but it's been so great having you on the podcast. There's been so much information that you've shared with us today, so I really appreciate that.
Thanks for having the opportunity. I hope this information gets into the ears of the right people and helps them a lot.
And listeners, thank you for joining us as well. If you liked this episode, we'd love you to rate, review and subscribe. And we hope you will join us for next week's episode. Meanwhile, for more information about living your best life at midlife, pick up a copy of Prevention magazine. I'm Zoe Mernier. See you next time.